Hello and welcome to Just Ask on EAO channel. My name is Hayley Edmonds and I'm delighted to be your host for your monthly appointment with an implant expert. And this week is no exception. Now, just before we meet our guest, let's find out where you're joining us from today in just the chat box just to the right of the screen. I know this is a very international show and we love to see and hear where you are connecting from around the world. So I'm just going to take a quick look. Federico, he's tuning in from Italy. Guillermo, he's tuning in from Mexico. Stefan, great to see you again, Stefan, from Germany. Berus from Austria. Andre from Portugal. This is a very international show thus far. Lithuania. Jose from Spain, and Abdullah from Cairo, Egypt. This is a fantastic start to what is going to set to be a great session today from Just Ask. Now, I'm delighted to welcome today's guest, Dr. David Norré, implantologist, prosthodontist, lecturer based in Brussels, Belgium. So how are you doing?
Fine, thank you. Thank you for the invitation. So I'm delighted to be here for the EAO, the first time I can lecture for, or at least have a talk with the guys of the EAO. So it's a big honor for me.
Well, that's what you're saying, having a talk. Well, it's an interactive session, if you will, and we want to hear from you. Please don't hesitate in asking Dr. David Norré your questions throughout the session. We want to hear from you. We want to make this as interactive as possible, and this is a great chance for you to kind of ask any questions you may have on today's subject. And now today's subject is, of course, predictable immediate full arch implant surgery. So firstly, Dr. Norré, maybe we can start off with a slight overview of maybe digital dentistry and maybe just going really to the basics of what it is before we really get our teeth into today's subject.
Yes, most of the time people think that digital dentistry, you need a lot of fancy things to be digital, but it's not true. The first thing is you have to think about what's the purpose of digital dentistry? What can we do with it? And what's the big advantage of digital dentistry? Because nowadays it's always something very fancy. All lectures are about digital, about scanners, about motions. But what's the essence of digital dentistry? And the only essence is to have to be predictable, to know what you're going to do, and that you can see up front what you see is what you get. And to have it, you only need easily three things to have a digital patient, because without a digital patient, what is digital dentistry? And the first question you have to raise, what is a digital patient?
Absolutely. So, I mean, I think maybe some people may be a bit more intimidated by any digital dentistry or any kind of complications or no, misunderstanding that may entail. But, you said it yourself, it's a very easy way or facilitates dentistry. So maybe, and you'll be able to explain to us today how this can help in the process that we're going to be discussing today, which is, of course, predictable immediate full arch implant surgery. So going back to the basics, how do you start off with this procedure using digital dentistry? How do you create, what are the very first steps in this?
Question? Can you repeat the question?
Of course. Yeah, so just maybe for the first steps in this procedure, I mean, with utilizing digital dentistry, I think we may have an issue. No, we're good.
No, it's okay. It's okay. Now, sometimes the connection is gone, but it's okay. What do you need to be a digital patient? In fact, you need three things. You need one good picture, because if you talk about full arch, you talk about full rehabilitation. And you need to know what's the smile design, what's the smile of the patient. So you need a good clinical picture, one picture, at least maybe two pictures. You need a digital teeth positioning. So it means by digital impression or by digitalized impression. You need a cone beam. And if you have these three things, you have a digital patient. You can do everything you want. You can plan whatever you're doing you want, but it always will start with the final positioning of the teeth. And for that, you need a digital patient.
So with all this these taken into consideration, and I'm imagining you're kind of acquiring a lot of data that goes along with that. So, you know, how would you go maybe onto the next step of applying these, and, you know, with this data acquisition to move forward?
But if you once you have the data, you have to know what you're going to do with the data, where you're going to store it. So most of the time I'm
okay, I think it's cutting out. We have I think we have an internet connection problem there.
Everybody on it.
No, you come back.
Oh, yes. Yeah.
Maybe if you could just repeat that part, please, Dr. Norré, because we missed it out.
So you need to have some platform where you can share all these data with the guys in charge, like the surgeon, like the technician, like the hygienist, like the designer of the implant guide, the guy who is going to design the prosthesis. So they need to have all this data. So you have to process and to see the data positioning. So you have to understand what is going to be the final positioning of the teeth before you can start the surgery, or at least planning the implants. So the first thing you need to do is a smile design, always. That's the first step of a digital patient.
And then, you know, going on to the teeth impression, digital or digitalized?
So no, I think now the penetration of the market is 30-40% of scanners, but you can take an alginet and just send to the dental lab who is going to digitalize the impression. For sure, you need a comb beam, you need the bone, you need the teeth, and you need the facial integration of it. That's the most important. And
you also mentioned function as well, the motion.
That for that device, you can have a device who is going to acquisition of the motion of the lower jaw, like the mod jaw is one of these devices. You can use it to have the motion of the patient, to have it totally digitalized. So you have the patient on your computer, and the big advantage of digital dentistry is that, like my good friend Florin tells us, you have the Control-Z function. In the digital world, you can always do and undo. You cannot do it in real life. If you place an implant wrong, you have to remove it or restart it. In digital, you can plan and replan and replace it again.
So I guess we're kind of really going there. There are three separate parts of this as well. There's, of course, what you're talking about is planification, planification of the process, design, of course, which is integrated into that as well. And that will be, of course, before execution. But how important is that step, the planification and design of any procedure?
The most important step. The most important step is to have good data. Good data gives a good surgery and a good planning. And a bad data give a bad.
Okay, so let's go back to how maybe you can start off with the beginning of how you can start perform FP1 or socket fit full arch cases. What are the very first steps to that? I'll just
yeah, no, back. No, I hear you back.
Yeah.
Yes, didn't hear what you asked me. Sorry, it's very bad connection. I don't know what's happening here, but I didn't hear you. You're blocked out.
Okay, so how to make a patient digital, that's the first step. And we've taken all of these points into consideration. Of course, now you're going to put any kind of, it's all about digitalizing the patient. That now is the next step, right? So you need facial pictures. Yes. They'd be necessary in the next step?
Yes, always the first step of the patient when it comes to your office, you always need clinical pictures, in digital teeth, and a comb beam. That's always these data you always will need it, always. So you need one good picture, and one good picture is with a full smile that you can integrate the teeth in the face. And then at that moment, you also need a digitalized teeth or digital impression to match the teeth in the face. And you need the comb beam to have the bone support for the full arch. You always need at least these three data, always. That's the first step.
Okay, and then after we acquire the facial pictures, what would be the next step after that?
Intraoral scan and comb beam. It's one appointment, always. Intraoral when you have everything, and then you go to the 2D smile design.
Into smile design, right? Let's move on to the smile design then. So we've done the planification, and then of course it's the smile design would be the next step.
Yes, That we do it also with for example, with the Smile Cloud. It's just a smile design app that you can choose the final shape of the teeth. I'm just going to show you, for example, an example of it. Patient is coming in, and we do a 2D design like this. In 2 pictures, we're going to add the final shape of the teeth. So just in 2D, to have an idea what face we want to have, the length of the teeth, the positioning of the zeniths, the positioning of the papilla. That's the smile design. The 2D smile design.
But these are all kind of algorithms that will also help the patient kind of project him or herself as to the result as well. And what potentially, I mean, it gives them a great idea of what the predictable outcome is going to be.
It's easier to accept the treatment than you're going to see what you're going to give them. The most important is that it's a realistic smile design. That's the most difficult for full arch. Or you're going to decide if you're going to resect bone, go to FP3, or you're going to try to keep the teeth to have it in FP1. And that's the smile design going to dictate it what's possible or not. But this one is just for acceptance and to have a look, because you cannot do anything with this. It's just to have a look. You have to go to 3D to be sure what you can do.
Right, but as you said, it does give the patient a good idea as to, what the outcome would be. I don't know if you maybe want to take this specific case and maybe explain the process and what he went through and what this patient had initially and what he wanted to correct, and of course the outcome.
Sure, no problem. There's a case we did a publication with together with my friend Weil from Tufts University. Is this one? The case is coming in like this. He's a 40 years old guy. He had a very rough youth, a lot of, let's say, drugs. And after, I think, 15, 20 years, he totally changed now, already 20 years ago. And he started really to treat him well. Some people said, yes, but look, this one is not very nice brushing. But if you see the first picture we saw at university, it was like this. So the most important part of these guys is that they are compliant for treatment. If they don't earn implants, you will not place implants. So you saw the evolution from this side to that's the initial one. And after 3-4 years, he had a very intensive perio treatment, and it was pretty good. But now everything is too sensitive, and he came to my office now to have fixed teeth. We discussed all options, but he wanted to have fixed teeth.
Okay. So what did you decide on? Okay.
So we decided to go to the data acquisition. So we will take the pictures, intraoral pictures, cone beam, intraoral scan. We discussed the treatment options. And we came out that we want to have all this data, and we will end up with 2 fixed bridges, 2 FP1s, FP3 lower jaw. So the first step is clinical pictures, cone beam, and intraoral scan. Always the same, always same data acquisition. At the moment we do the data acquisition, we go through the data process, and that's maybe a little bit more difficult, but the data acquisition is very easy. That's something a dentist has to do. And all the rest is data improvement, because now we have a lot of data movement. You go from a 2D design, 2D smile design, you're going to migrate it into a 3D designing software like Exocad, where you convert a 2D to a 3D mockup to have the final positioning on the model or the arch of the teeth, to know where you can have the implant positioning, because the implant has to be planned on the final positioning of the teeth. You cannot, if you have an FP1, the implant has to be very, very well planned. So at that moment, you migrate the 3D design to your planning software, and you plan your implants accordingly of the final positioning of the teeth. Once you have done the implant positioning, you export it back, because what's the biggest issue with all or full arch, if you want to do it immediate, is the predictability of the immediate loading. I like to have the final bridge made up front. So you need also a guide to place the temporary bridge. And then once you have planned the implants, you have to export the implants again, and accordingly to the 3D mockup. And this one you're going to export again into Exocad to design a temporary bridge which fits the implant positioning. And this temporary bridge you have to import again into your planning software to make a second guide. So in fact, you have 2 guides, one for the implants and one for the prosthodontics. And that's the big advantage, because you're going to be very, very predictable.
How precise are they though? I mean, is there any kind of room for error in these? I mean, you're talking a lot about...
I don't never talk about precision, I talk about accuracy. We know we are not precise, we are accurate. So we know we are always between 1 and 1.5 millimeters. But the first thing I do in every guided surgery, I will always place my implant deeper. So I don't want to be precise, I want to be accurate. I want to be sure my implant will be within the same zone that I planned. So the holes of a temporary bridge will always be 1.2 millimeters bigger than the implant. So the holes will be 5.2 millimeters and not 4 from the cylinder. To have a little bit of room.
Okay, I have a question for you. As I said earlier, this is an interactive session, so I'd really like to encourage everyone to to ask any questions they may have. And Stefan Fickel has asked one: is there a chance to try the final result before final treatment? I mean, I'm not sure whether that's referring to also
normally you can
the
do
visuals.
Yes, sure, of course, you can do the mock-up in the jaw. Normally you go you go to a functional mock-up and you can do it over the teeth. It's very difficult because you have to understand, if you do a mock-up, it's always wider. You will always put it on top of the teeth.
Of course.
And then you're going to have a very big teeth. The teeth are bigger, so it's not very representative for full arch, especially if you're going to extract everything. What's also very important to understand is, in case to FP1, the design of the teeth has to be slightly inwards. So if you do a mock-up on top of the teeth, you will be a big difference between before and after. So it's always more tricky for full arch because they're additive. They are most of the time, they are resection cases.
David, just it's a personal question actually with regards to 3D printers. Is this something that is widely available in a lot of surgeries? I mean, is this something quite selective? I mean, how did this kind of access to these work?
I didn't understand the beginning because you was cut away. So you mean the patient, or who is accessing the work?
No, just with regards to 3D printers, how accessible they are. I mean, I'm presuming that not everyone has immediate access to these. I mean, is it something that's quite widespread and quite available to utilize? Okay. I think we have a little connection problem.
I'm going to repeat it. I think I was gone. I only have 6 months ago my 3D printer. So most of the time it's done in dental lab or in a planning center.
Got you. Okay. And so, yeah, I think that answered my question anyway. Now, with regards to planning centers, maybe you can tell us about that, the next step, your relation with planning centers, and how does it function with regards to kind of passing on the work to them?
What I do is always online. It's in SmileCloud, so they remove it. I'm just going to see one slide. I don't know if you see it immediately here. The planning center, where is it? It's about this one. For me, what's the planning center? They are guys who are very, very analytic. Most of the time, I put everything on a platform and they download everything and they start matching the intraoral scan with the cone beam. And it's very precise work, and it's done by guys who are much more trained than we as dentists. The first thing they do, they place the implants where they think they will be placed. And then it's our job as a dentist. I think we are more creative. We are a little bit more MacGyvers. So our thing is what we want to plan. The technician is doing all the analytic process, and we are just doing what we want to plan. And then you can play a lot. And that's what I like about working together. These guys are really analytic, and I am more creative.
Okay, so that's quite an interesting collaboration that you had with them there. Okay, so now let's move on to the next step where you were. We'll just go back to where we were prior to this. Maybe with the case, the 40-year-old guy, because that was a particularly interesting one. Oh, here we go. All right.
Yes.
Only approval. Oh, here we go. Only approval planning center.
So this one, all these data movements, I'm sure a lot of guys who are looking here are saying, what the hell is this? It's easy. You don't have to do anything. Someone is doing it for you. You as dentist only have to do data acquisition and send it to a planning center, and they will do it for you. You just have to say to them what you want. That's the easy part.
tell them what you want. So of course your role as dentist, as you said, you know, is it the data acquisition, but also of course diagnosis. But you know, it's so important to have all of that as well, and such a great relationship with the planning center. So this would be the full. We're just seeing all the benefits of 3D printing, for example, with regards to mock-ups, with regards to surgical guides, etc. I mean, they seem to be able to. They seem to be such a versatile machine in digital dentistry, and so important.
Depending on what you want to do, because my temporary bridges are still milled. So if you want to have precision, you have to mill. The printers are not yet the same precision as milling machines. So the temporary bridges are milled, the guides are printed, the guides, because they have to be accurate, not precise.
Okay, right. So let's move on. After the planning center, what's the next step after that?
Once you have everything, you can start the surgery. You receive from a planning center 3 things. You receive a guide, like here, your surgical guide. You receive your temporary bridge. And you receive a positioning appliance. You receive these 3 things, and the positioning appliance is fitting on the temporary bridge, and then you can start the surgery.
Okay. And now let's maybe discuss the actual surgery. We can go back to the case if you only have the specific case in your files. So going back to this gentleman here, maybe I have got some questions as well. Let me have a look. What is the best way to find the occlusal plane and vertical dimension if there is no reference left? Full digital approach possible? And
yes, sure.
Sandro.
Look here, I can show you. I mean, maybe not in face this case, but I can show you how we did this one in 8 sessions. This, you lost everything. No vertical dimension. You had the class 3. You can do everything in full digital. But for this one, you need the motion. You need the moja, for sure. You have to make it in full digital world. And one thing is important. Once you enter digital world, you have to stay in digital world. Don't go too much analog, because then you're going to make too much fault. But yes, you can. Not an issue.
Theodore wants to know, I see a lot of practitioners showing their FP1 cases. Interesting point. For how long do papillas last? I'm a beginner on this, on next concept, and I'd like to see a realistic opinion, or have a realistic opinion.
But that's always the question I receive. How long will the tissue stay with an FP1? What would you do if you lose a 4 anterior teeth? The papillas will always, I'm lost you again. Hello.
I think, can you, I know we've lost Dr. Norré again. Let's just see if he can hear us. Can we hear you maybe? No? Okay, maybe we should try and reconnect. Thank you once again, everyone who is connecting. Continue to ask your questions. Dr. Norré is here to answer them, and he's doing a fantastic job of that so far, albeit does a few connection problems, but doing a fantastic job. So
you hear me?
You are. So healing, right, let's move on to the next. Okay. I can hear you now. You're back.
Yeah, it was just about the question about the FP1, how long does it last? I think if you see this tissue like this, I think it will last for a very long time. You need thickness. It's about everything. It's also for single or partial implant bridges. A full arch is just like partial bridges, but 3 or 4 is the same for me. So I don't see any issues with FP1s, with tissue.
Okay.
If you have thickness.
How does the planning center determine the vertical dimension?
No, the planning center determines it. I'm determining it. It's my job. I'm a dentist, not the planning center. I'm going to say to them how much I want to raise, how much I want to do. That's about the 2D with the motion, with acquisition. You will try it in the mouth with the moja. That's something you are going to have to test it. Let's make it more complex.
I mean, with this procedure, there are so many variables on each step. I mean, you must almost probably become quite dependent on digital dentistry, because there's so much to take into consideration over the process.
But you have to, I think people has to trust it. If you trust digital, you know the computer will not make mistakes. The computer is always right. It's depending how you see the data.
Trust the process.
Trust the process. The digital is always right. The computer is always correct. We are depending how we will process the data.
Okay, it's how we acquire and how we utilize that data that we collect. So immediate temporization material, any reinforcing material?
No,
that's from
only PMMA.
Okay.
Thick enough. You have to have thickness and no extensions.
Thickness, no extensions. Does the doctor have breaks of PMMA? Would he consider any intractable welding as a solution for reinforcement?
I know some guys in Russia are doing it, intra welding. I don't need it. I have sometimes for sure have breakage, but at that moment I repair. It's digital, so it's just mill it again, and 24 hours later I have a new bridge. But it's most of the time it's when everything is too precise that it breaks. Then you don't have enough material around the cylinders to connect with the temporary bridge.
Okay, thank you. Now let's go back to what we received from the planning centre. Then we get, here we go, fantastic. We've got the 3D printed, simulated extraction, surgical guides, temporary positioning appliance, etc. This is the next step?
Then we start the surgery, because everything is done. We did a 2D design.
Right.
And the planning, that's okay, we're going to skip this one.
Okay, you're cutting out again. But we will move on to the surgery. Here we go. So STAR, this is a STAR concept. Save 3 acceptable routes. Are you with us?
Yes.
Oh, good, fantastic. So yes, tell us about STAR, save 3 acceptable routes.
Yes, so what you do is you're going just to keep 3 or 4 teeth, because we know that for guided surgery, tooth-supported guides are much more precise and predictable than tissue-supported or bone-supported. So what you're going to do, you're just going to do surgical extraction in the planning, and you're just going to keep 3 to 4 teeth to stabilize the guide.
Okay, I got you.
And then you're going to have a tooth-supported surgery, much more precise.
So it could be 3 or 4. It's just to kind of have a guide. Now, talking about STAR and STAR concept is something I'd like to address with you before we move on to the next step, because you were asked to write an article on that very subject, and it was you actually asked by Dr. Karim Dada.
Exactly.
Maybe you could just tell us about how that came about and why he specifically asked you to write that specific article.
I was doing a last surgery in Paris, in Mitri Davaspana's office clinic, and there were 400 people looking. And I did a full arch, like I'm showing you now. And for me, it was nothing spectacular. It was just 2 guides. And Karim is the head, I think, from Quintessence France. And he started the surgery, and the patient go home in an office. I never saw the patient, in an office I never worked, go home with a perfect positioning teeth within 3 hours. And he called me 2 days later to say, David, I never seen this. You should make an article. And it's why I started writing an article together with Weil Atz from Boston about this concept. It's
the actual article is available to read for any professionals in the International Journal of Computerized Dentistry.
Exactly. And this case what I'm showing now.
Exactly. So I thought I'd link that in. So let's go back to, well, it's a fantastic article as well. So I do encourage anyone who is connected today to read it. It's in the International Journal of Computerized Dentistry, and it is on the STAR concept, or save 3 acceptable routes. So yes, please, so this is during the surgery.
So you do surgery, remove the teeth except the stabilizing teeth. Right. And then you start the surgery. That's also very important to not using the anchor pins as anchor pins. The first implant is the anchor pin. So I'm going to show you a little movie. I don't know if it's going to go or not. You see the movie? It's okay?
Yes, fantastic. Yes, it's working fine.
So you have to have the bone mill and the first drill are the most primordial to have a very predictable implant surgery. And then you go 1 implant by 1. And what I always say in my lectures, guided surgery is not your BFF. It's not brainless, it's not fast, and it's not flapless. But it can become your best friend forever. And that's very important.
I thought I misheard that. I said, did you just say BFF? But you did.
Yes, I said
Okay, sorry. Yeah. So going back to it. So it's
I do one implant by one. I will not drill all implants together. And the first implant, it's a mount with screw retained on the implant. That's for me primordial, because you see no anchor pins are placed. The first implant will stabilize the full guide. It makes it very, very predictable. And you will always place the first implant next to a tooth or between two teeth. And you see the implant stays in and it stabilizes my guide perfectly. And now I will enter all my implants one by one.
Stefan Fickel wants to know, are you considering tilted implants and then angulated abutments?
I consider tilted implants for sure. I hate angulated multi-units. I hate it. I don't like to use it. I'm a pros guy, so I had too much problems with it in the past. But yes, I do it if it's necessary. But if I can place them straight, I will always place them straight. But yes, I do pterygoid implants. Yes, if necessary, I will do. I think I did last year a lot of full arches, and I used 4 angulated multi-units.
Do you use temporary abutments that are straight for the connection, and do you have to grind them depending on angulation to be able to adjust the insertion direction?
But I use the multi-units. I don't go direct implants, so I don't have to trim the connections. It's always on multi-unit level.
Okay, Rosen wants to know, how do you correct uneven gingival margin and papilla? Could you tell us more about the emergence profile if there is anything different?
There are a lot of questions together.
I know there's a lot of questions, and they're really loaded questions, aren't they?
So it's a lot of questions. So the first thing is, what if you have uneven gingiva? Then you can do or grafting to get an FP1, or you're going to remove tissues with a stackable guide, something different. I can also show it, that you're going to remove it. It's all depending on the smile line. So it's a very broad question. So that's a little bit bone removal. If you need bone resection, you need guides who are stackable. You cannot do it with this type of guides. For emergence profile, that's the most tricky thing to a very nice papilla, is that the teeth has to come more inwards, 0.6 millimeters, and a little bit slightly more apical than initial. So it's also about 1 millimeter. So you have to put the teeth more inwards and a little bit more coronally. And then most of the time it's worked perfectly out. Except if you have, like the case I just showed you very fastly, then you need much more and you're going to go to FP3 for sure. You can do FP3, I don't like it, but yes, it's a treatment option.
I think can you hear us?
Yeah. Yes.
Good to hear. And how do you, Theodore wants to know, how long do you keep your patients on provisionals? Any difference between the mandible and maxilla?
I always do 4 months.
4 months in provisionals, okay.
And sometimes when it's a live surgery, it can take 1 year without any problem. But 4 months is standard.
And I'm imagining you have to kind of impose oral hygiene routines to these people. I mean, that maybe been a little more negligent before this process.
They have to prove me before I start that they own implants. They will not start implants if they not prove me that they brush their teeth. Otherwise, I will not do it. Never.
Okay.
Afterwards, it's too late.
In what cases do you find it helpful? What movements do you record in order to assess the planned occlusion?
It depends what type of case that you're going to do, which type of movement. In a mojo, I will always do the full opening and try to close them till the first contact. That's the first movement that I want to see. What's their first contact? I will do the CR and deduction left-right. So I will accord as much as data as I can. Yeah. I think the swallowing is very important movement. In fact, it's the same as you do a full edentulous cases. If you do a full removal, they are the same movement that you have to acquire. It's nothing more than a full removable denture or full arch. Full arch is easy. It's a full denture, and you can have all single implants. I think sometimes we make it much more difficult than it is. It's like a full denture.
Okay. And Abdullah wants to know final restoration material technique. Well,
zirconia. Most of the time, if you go or immediately to the final restoration, it's okay. I always will go like a full zirconia, and I like to make them like this in 2 parts, 2 or 3 parts. I had a lot of fracture of full arches zirconia, so I like to make them split. So not 1 arch, but in 2 or 3 parts. That's why I like to place a little bit more implants. Every choice has its consequence.
Orlando wants to know, do you perform any cephalometric measurements, airway atlas axis position?
No, I don't do that.
Okay.
For me, it's more an elastic. I'm not the biggest guy in occlusion. For me, the mouth is the best articulator. So the patient is there 4 to 6 months with his temporary bridge, and the bridge will be grind out. So you have the best movement you have it in the mouth. You will see it after 4 to 6 months. Without the glad part, it's soft material, it's PMMA.
We have a lot of questions this evening, Dr. Norré. You're not going to be able to get through many of your slides, right? Which is great. So. This is the objective. This is what we want. Do you prefer titanium bar with separate teeth bridges?
Oh, Malo bridges. The problem is if you do a titanium bar with 1 zirconia overlay, it's never nice. The teeth are only fused to each other. I don't like it because you need a lot of volume. If you want to have single ones, titanium bar with 12 single crowns, it's possible, but the pink is a problem. How are you going to do the pink? Difficult to make it like porcelain, and I did it in the past. It's very expensive, but the problem is the pink. And we did with pink resin, and after 3-4 years, you see a black border around the crowns. So I don't have very nice experience with let us say the Malo bridges.
Earlier on, you did say trust the process. Digital is, extremely reliable. But have there been any instances where you may have got not the outcome you may have wanted through utilizing digital dentistry?
The problem is the planning. If you plan the implants in positions there is no bone, you will have an implant which is not in bone. You understand what I mean? Yeah. It's always about the data acquisition quality and the planning. And what sometimes happens if you do it a lot, sometimes you are a little bit too fast with the planning. You say, yes, I think it will work. And in reality, you always have more bone or bone in a different position than you plan. So with experience, you go farther and farther, and you go thinner and thinner, and sometimes you cannot place an implant you planned. It's why I always prefer to plan more implants. The issue is also primary stability of the implants. Also something in a full arch. Are they stable or not? So I always like to plan more implants than I will place.
Dr. Gleeson wants to know, do patients have the right to eat any food on full arch immediate?
Sure, but nothing too hard. They have to eat. They can eat for sure, no problem, but nothing hard, no French bread. You can eat hamburgers, it's not an issue. They don't eat spare ribs, don't eat
apples,
don't eat hard things. Just be cool for 2 months. 2 months, they cannot eat anything hard. So if you do upper, lower, I will always do the upper first, and 2 months later, I will do the lower.
Sounds very reasonable. Okay, so upper first, and then 2 months later, the lower. Okay. So you separate the all. So you separate the all on 4 bridge into 2 parts. Okay, so you separate the all on 4 bridge into 2 parts, right? Okay, I think we have. We may have lost Dr. Norré.
I hear you still.
Oh, you just don't want to answer.
Yes, I hear you. No, I said.
Okay.
I said you cannot separate all on 4. It's not possible. You only have 4 implants. That's not possible.
Sorry, we just didn't hear the response. That's why.
The all on 4 you cannot split. An all on 4 is, I think, de facto something with metal base, because you cannot make a full zirconia bridge with so long spans. So it's an all on 4. It will be with metal, and it will be one piece. If you place 6 implants or 8 implants, then you can segment the bridges.
Okay, well, I've got 2 more questions for you. One is from Theodore once again. Oh, just we can't. Yeah, one once again from Theodore. So the final FP1 restoration is just made only of zirconia and abutments.
Yes, like
okay.
This, like like I show it.
Oh, Berouz wants to know: are night guards mandatory for your full arch?
Yes, yes, of course. That's like this. Always protect your beauties of your jewels. Always mandatory. And I have a very good tip if they want to know how I'm sure they wear it.
Protect our precious jewels.
Yeah. So what you have to say, my wife is also a dentist, and she has a night guard because she grinds a lot.
Oh, I see.
And she's very picky. She's very cleaning very hard. And I have one of hers in my office. And I show the patient hers, who's 1 year old. And I show, look how dirty this one is. If yours looks cleaner next year, it means you didn't wear it. And you don't have any guarantee.
Wow, you're tough with your patients. It's good to hear. You're really, yeah, you're absolutely right to do so.
Yes.
Beauty in the okay. And then one last question, right? Maintenance protocol. Do you recall your patients every now and then to unscrew prosthesis and clean? Whoa.
Yes, I have it here. Of course, maintenance is also in my lecture. I always do prevention. So you have to clean before. You need to have tissue. And then I do like Marta described in our last article, you can scan the QR code, is a 4-3-2 approach. The first year you do it 4 times a patient. I see every 3 months a patient back. If everything is go well, the second year I see him 3 times.
And that's scan code. That code actually will direct you to an article on prevent peri-implant diseases in edentulous patients with fixed implant rehabilitation. I
didn't understand the question, sorry.
It wasn't, I was just actually, with regards to the code, I was just explaining what that would actually direct you to, and it's an article on preventing peri-implant diseases in edentulous patients with fixed implant rehabilitation.
Yes, and it's about the 4-3-2 approach is also described in that article.
Fantastic. Maybe just a few final words on anyone that may have any doubts with regards to really kind of investing in digital dentistry. I mean, as I say, this is a global show. I don't know if anyone's necessarily completely au fait with all of the processes and software that you have mentioned this evening. But how would you maybe not convince someone, but reassure someone that this is a fantastic process and a way of of doing dentistry?
Do you hear me again? Do you hear me again now? It's better? Yes.
Yeah, we can hear you.
Yeah. Well, for me, the only investment you need is a comium CT. If you don't have a comium, it's difficult to place implants.
Okay, so it's quite accessible.
Yes, for me, yes, because you can take alginets and you can scan the alginets. You can take facial pictures with your iPhone if necessary. So it's not the expensive thing. You need software and planning centers.
Well, on that note, I am going to thank you, Dr. David Norré, for this evening's discussion. It was a fantastic Just Ask. We've had a huge amount of interaction from you guys who have tuned in, and it's obviously great to have that. I don't think we managed to get through everything, but of course we were able to address so many different things, and really some fascinating. We explored some cases today, and yeah, thank you so much for taking your time to take part in this Just Ask, Dr. Norré.
Thank you very much, and thank you for the invitation. It was very fun to do. So thank you.
And it was a pleasure to have you. Now, just before the end of this show, the EAO Congress is a joining meeting with the DGI, the German National Association, will be held in Berlin from September the 28th until the 30th. Don't miss the latest updates in implantology about innovative technologies and treatment strategies, and enjoy great networking opportunities with your colleagues. Now, this is a fantastic opportunity, so please do join us. It's September the 28th until the 30th. Register before June the 15th, so you've got 10 days, and benefit, of course, from the early bird rate. Registration fee for student members is only €99. That is a bargain. It's going to be a fantastic opportunity to meet your peers, to exchange with professionals. All of that is, of course, the EAO Congress. All of the information is in the description box below. Once again, thank you very much for Dr. Norré for this Just Ask session. My name is Hayley Edmonds. Have a lovely morning, afternoon, or evening for wherever you are tuned in from around the world. Take care and see you next month.
Thank you. Bye. It's
Oh,
just
good.